Welcome everybody to our vaccination conversation. We appreciate all of you who are already logged on, all of our early uh, attendees on today. Tonight is going to be special. Tonight is going to be amazing as we would approach a subject that's going to be so relevant to decisions that all of us have to make in the very, very near future. Before we get started, however, I want to welcome our Blim family, specifically our Beacon Light of Homer family, all of you that are joining us from the Homer area. We appreciate you sharing with us and under the very capable leadership of Bishop Herb Andrew. We thank God for him giving us this opportunity even to share this with you tonight as your normal Wednesday night Bible study. We also want to, of course, thank God for our apostle and overseer, Bishop Darrell Brister, and all of the Beacon Light churches that are connected with us on tonight. I believe that this particular discussion tonight is going to be so pertinent to the decisions that we have to make concerning vaccination, concerning all of the things that we're hearing in the news. We have seen and witnessed over the last several weeks the power of a lie and mistruth, and how our country can just be unraveled if a lie is repeated long enough. And we do know that there are several both lies and myths around vaccinations. And our goal tonight is to bring some clarity and some truth around this very, very sensitive subject that all of us are going to have to embrace. Let me encourage you before we do that to first like, share, and tag. I want you to do those two things for me: like, share, and tag. If you could do that very quickly, like this, share it, and tag, because we want to be able to touch and reach as many people as possible with our discussion on tonight. I want to pray, and then after I do that, I'll turn it over to our Director of Health and Healing Ministry, and she is going to lead us in this particular discussion on tonight. So let's pray. Father, we just thank you and bless you for this day that you've given us, Lord God. If you've taught us nothing over the last 13 months, Lord, you've taught us never to take anything for granted. And so today we thank you for this day, the health and strength that's in our body. We thank you, Lord God, for the relationships that we share one with another. And more importantly, we thank you, Lord God, for your covenant grace that rests upon our lives. We thank you that tonight is going to be an opportunity for truth to go forth, Lord God, for information to be disseminated. And God, all that we ask is that your hand would continue to rest upon us. We love you and we bless you now. In Jesus' name we pray. Amen, amen, and amen. All right, I want to introduce to us tonight and present to others this awesome woman of God. She is, of course, anointed in the area of medicine and health and healing. She has done a tremendous job leading our church in the area of health and healing. But she is, of course, a doctor of nurse practitioner programs at LSU School of Nursing in New Orleans. And tonight, I want her to come on with us as we would introduce this array of competent and capable guests that we have that are going to give us some great information. So I present to you Dr. Leanne Fowler. Can y'all put some hand claps in the comments and let's welcome her, Dr. Leanne Fowler. Leanne, we welcome you tonight.
Thank you. Thank you, Bishop. I appreciate that. I appreciate you allowing us to use your platform to get some information to our community, to get some truth, to help inform, to help eliminate fear. So I applaud you for that, sir. And I want to introduce a panel of experts who have been serving our community for a long time. We are aware of many things that have sprung up since this pandemic, but these professionals, these experts have been working in their field long before this pandemic to try to eliminate health disparities. So first, let me introduce to you Dr. Sandra Brown. Dr. Brown serves as the Dean for the Southern University School of Nursing and Allied Health. She is also the co-chair of the Louisiana COVID-19 Health Equity Task Force. Dr. Brown is a professor of nursing, has more than 31 years of nursing experience, and has achieved local and national recognition with the Lifetime Achievement Award from the Acadia chapter of the National Black Nurses Association, induction into the LSU Health Sciences Center School of Nursing Hall of Fame, and as a 2017 fellow in the American Academy of Nursing. Dr. Brown is a family nurse practitioner and experienced in primary care services, and she is a nurse researcher where her primary research focus had been in the advocacy of young women of color in historically Black colleges and universities. Welcome, Dr. Brown. The next panelist I'd like to present to you is Dr. Takeda Ferguson. Dr. Ferguson is currently an assistant professor in epidemiology at the LSU Health Sciences Center School of Public Health in New Orleans. Dr. Ferguson has expertise in chronic disease epidemiology, and her work focuses on taking a biopsychosocial, big word, biopsychosocial approach to understand the social environment as well as traditional pathophysiologic measures on the influence of cardiovascular and other chronic diseases such as diabetes, metabolic syndrome, and cancer on our Black and underserved communities. Dr. Ferguson has experience in the design and management of multi-site clinical trials, very important, surveillance data systems, and longitudinal studies in multiple population cohorts. She is an associate director of the Louisiana State University Health Sciences Center Comprehensive Alcohol Research Center, Data Management and Analysis Unit. She is the co-principal investigator for a project that investigates community and interpersonal stress, alcohol, and chronic comorbidities among people living with HIV. Dr. Ferguson, we welcome you.
Yes, welcome.
Next, Dr. Keith Ferdinand. Dr. Keith Ferdinand serves as a professor of medicine at the Tulane University Heart and Vascular Institute and as the Gerald S. Berenson Chair in Preventative Cardiology. Dr. Ferdinand is board certified in internal medicine and cardiovascular disease with specialization in nuclear cardiology and clinical hypertension. He has more than 40 years of practice in medicine with a focus on the evaluation and control of cardiac risk factors among communities of racial and ethnic minorities. He also has a life of service as a leader in multiple national organizations, including the Association of Black Cardiologists, the former chair and chief science officer in the American Society of Hypertension, and as a board member of the Healthy Heart Community Prevention Program. Dr. Ferdinand, we are blessed to have you. Welcome.
Welcome.
Last but certainly not least, and very well known to our church family, is Dr. Tony Dennis. Dr. Tony Dennis is a board certified otolaryngology physician with a robust practice as an ENT, head and neck surgeon at North Oaks Medical Center. He also serves as gratis faculty with LSU Health Sciences Center School of Medicine's Department of Otorhinolaryngology. And in his medical education, he has earned a Master of Science degree in microbiology with a concentration in viruses. This led him to help the Infectious Diseases Service at North Oaks to serve that inpatient and hospitalized community in the COVID-19 units and caring for him over the last few months of this pandemic. Dr. Dennis, thank you so much for your time and service. I took the time to read their abbreviated biographies to demonstrate the amount of time and energy that was spent focused on our communities, focused on our needs, for the needs of Black communities and underrepresented racial, ethnic, gender, any other group, okay? So with that being said, let's look at the facts. Let's think about what we know today about the conversation we will have. As of January 25th, which is 2 days ago, there have been over 392,416 total cases. And I gave you the exact number because those are human beings. Over 344,321 persons have presumed to be recovered from this illness. However, over 8,688 persons, mothers, fathers, children, grandparents, significant others, that's almost 22% of the total amount of people who've been infected with the COVID-19 disease, have died. Today, there are over 1,600 persons still hospitalized and 200 persons being ventilated in our hospitals across the state of Louisiana. When we drill down to the Tangible Hope Parish, there are over 10,871 cases. This is as of Monday. And within this parish, 232 deaths. That's congruent with the state average of 21% of people dying of those who are infected. If we drill down further, the greatest age group that has been infected are those aged 18 to 29. That age group has the most positive infections. But we know that those who are more vulnerable to the disease have experienced disability and they've experienced death. If we were to drill down even further and we were to look at the ethnic demographics of the persons who died from COVID-19, the leading ethnicity are Black Americans, Black Louisianans in our state, 39.63%. Other ethnic groups are varied across white populations, American Indian, Asian, Hispanic white, non-Hispanic white, but 39.63%. The underlying conditions that are associated with these deaths and placing them at great risk include hypertension being number one, diabetes being number two, any other cardiac disease, and some other chronic kidney diseases. And we know that there are other chronic diseases that also affect our groups. In the Tangible Hope Parish, I want you to know that although the largest number of people who live in this parish are not Black, there's only about 30% of this parish, maybe more, that identify and select Black as their racial identity. The percent of deaths is much higher in this smaller population of people. So this brings me to Dr. Sandra Brown. I want you to talk to us about the health disparities in the state of Louisiana and your work as the chair, as the co-chair of Louisiana's Health Equity Task Force, COVID-19 Task Force. What's been done to date? Given these disparities, what work and what energy that people may not see is at play?
Well, thank you, Dr. Fowler. And thank you for your meaningful contributions that you are providing as a member of our task force, as well as Dr. Keith C. Ferdinand, who serves on our COVID-19 Health Equity Task Force. And thank you, Bishop, for hosting a platform where we can have real-time dialogue about this issue. I'd also like to thank Governor John Bell Edwards for appointing a health equity task force. He took a bold step. He heard our voices and he took action early on, because just as Dr. Fowler cited the numbers, we saw early on that African Americans were disproportionately infected by COVID and dying from COVID. We are 9 months into our work as a health equity task force. We have over 68 members from across the state of Louisiana who are subject matter experts, from physicians to academicians to scientists, to NAACP, Urban League representative, and faith-based coalitions. The governor asked us to look at health equity, not only in the lens of COVID-19, but as it impacted our state of Louisiana. And we saw that this was an awesome opportunity for us to take a deeper dive. What COVID-19 did was snatch, it was like a curtain was snatched and we saw what was behind the curtain. Louisiana ranks 49th in the nation as one of the least healthiest states in the United States. What this means is that Louisiana is sick, and it was sick before COVID-19. We also rank third in our nation for our poverty rate. So these health disparities that we talk about have existed for a long time. COVID did not cause it, but it certainly did reveal it and expose it. When we talk about health equities and health disparities, we're talking about hypertension, diabetes, obesity, and lung disease. And so what we found as a task force was that people who live in poor neighborhoods have worse health outcomes. And if we look at zip codes, you've heard the saying, a zip code is more important than your genetic DNA code because it can tell us what's in your neighborhood, what's not in your neighborhood. Do you have access to a grocery store? Do you have access to health care? And so as a health equity task force, we're all about health equity. We feel that where you live should not determine whether you live. So that's pretty much the basis of our work. We're looking at 9 priorities: testing, making sure that everyone has equal access to testing. We're looking at messaging and communications and using platforms as you all have with our faith-based communities to make sure that our messaging and messenger is delivered by trusted sources. We're looking at special populations, our prisons and our nursing homes. How are they impacted by COVID? We're going to propose regulatory policies that are going to impact health equity. And we're also looking at racial disparities. So we still have a lot of work to do. COVID is not over. And so now our big goal is on having real-time dialogue about COVID-19 and the vaccine. And I'll just stop for there.
Yeah, thank you very much, Dr. Brown. I think that that brings light to sometimes we hear all of the noise in the media and we don't realize how much work on the back end is being done to make sure that there's access, equal access to everyone. So now I pivot to Dr. Ferguson. You know, there's been an enormous amount of mixed messages in the public regarding this pandemic, social distancing, masking, and now with the vaccine. So, as an epidemiologist, particularly with the focus on health equity, with all of that mixed messaging, can you share with us why it's so important that our communities be informed with the right messaging and where we can go to get the right messaging to be informed?
Sure. I first would like to say thank you. Thank you for the invitation to be here today and for having me on the panel. So thank you to you, Dr. Fowler, and also Reverend Aber, for this time, and Beacon Light Ministries for the time and opportunity to be here to share information, be able to talk to our community members. So to me, one of the first things in thinking about tonight and us talking, and the question of why, the first question, why it's important for Black and Brown communities to pay attention to health disparities is first because there should not be a disparity, right? There should not be a difference. We should not have to bear unequal burdens of diseases. So if in the state we're making up 32% of the population, we should not be making up 30, 50, 60% of cases, or that representing a bigger number of deaths than the percent of the population which we represent. We should have health equity, right? So that's enabling equitable access and having optimal health for all. And we should be afforded that right, and we should have it. It should not be acceptable for Brown people, Black people, our African-American communities to be dying of higher rates or to be experiencing these diseases higher than other people. That should not be acceptable. So it's important for Black and Brown communities to be alerted to our own health and the health of our community. If not us, then who, right? If sometimes there is levels of mistrust for community or for other people, if we're not trusting the majority, then we have to look within ourselves, within our communities, to look out for our communities and who's going to take care and care about our communities more than us. or people that look like us, people that look like you and me. Sometimes other communities or people or race, ethnicity groups, or leaders might not be aware that there are higher rates of illnesses and diseases or risk factors, things causing poor health and illnesses. So we do have to be careful to make sure that we have the data to be able to look at it. Often in history, sometimes the data was not parsed out. If you even think about in COVID, that the initial rates of the disease and the number of cases were being released, they didn't parse it out by race. So we could even see and tell and look at the differences. And when we started to look at the data in that way, of course, I love data, was asking and looking for the numbers too. And when it was started to be released, we all saw it. As Dr. Brown said, the curtain was pulled back and revealed. And that part of the curtain for COVID and how it was impacting our communities was also revealed. We have to push others to care and to pay attention to these numbers, and not just pay attention, to know it and then back it with financial support and provide aid. As our community, we can also help lobby and direct dollars potentially and different health initiatives to our communities, so we can get that aid and we can see. Sometimes we're better in tune to our own communities too, is what can help and what can identify what activities or what public health campaigns might work for our community, or the type of messaging that might work, versus people that are not part of the community might not necessarily understand. So it's wonderful that the governor put together this task force, and there are people that look like us and from these communities that are part of the task force who can understand the problem and understand the context. Because sometimes even people looking at the data, and when we parse out the numbers, being able to understand what those numbers mean. And having a broader, the numbers might be true, but is it being interpreted correctly, and understanding what those effects are for our community, or what's causing those issues, and how to interpret the data. So in terms of where to go for good information, and I'm glad to know, and we've been putting it out there, we hear as we've gotten wrong information off of some social media platforms, or depending on who's saying it, that a lot of people come more in tune to understanding the CDC, them being a source of information, tuning into what that organization is looking, or what it's saying, going to the website and identifying that information. But of course, what might be an easier reach for us is your doctors, is our primary care doctors, our physicians, our nurses, going and tuning into your healthcare providers and asking them questions. I'm a big proponent and know that we should be, and for my family members, for myself, that we have to be our own we have to be our own health advocates. So asking questions, tuning in, looking, and you have to, of course, we have to do our own research. We might not all have the tools and understanding, but collecting data and going to those reputable sources like your doctors, like your nurses, also to, I mentioned the CDC website, but also our health department website. Some of the information that's there. Sometimes that's the present and open information. It might not necessarily always have the latest information, but it will, and it will be reputable, and it will be true information versus what we might pick up on just, Facebook post or from a friend.
Thank you so much. I'm so glad that you brought up the CDC, because there has been varying information that's come from the CDC. So we know that this pandemic hit us like a ton of bricks. Things happened quickly. People pivoted to prioritize resources, time, and efforts toward controlling this pandemic, providing resources to hospitals and clinics and all healthcare agencies to make sure we could care for everyone. And we learned as we tried to manage. So some of those changes happened because of how we learned information and pivoting from what we learned, but it is still a reliable resource. We also have to recognize that there are communities that don't have access to technology, that don't have access to the internet, don't have access to steady phone lines or electricity or food, or, it's just not their priority. So that's where this becomes a really, really meaningful vehicle of motivating one another and informing one another, so that we could have viral spread of accurate information across our families and our friend groups and our social groups. So I appreciate your comment, Dr. Ferguson. And we are going to pivot now to Dr. Dennis. Dr. Dennis, the mRNA Pfizer and Moderna COVID-19 vaccines have now been administered to over 350,000 first-line healthcare providers and nursing home residents. Um, there's been some mixed messaging also about the vaccine that we need to clarify. The term Operation Warp Speed, political divisions, social media, and any other source of confusion were sources of fear driven messages often. Sometimes they seem to have exacerbated the public's trust. There's a reason for mistrust, and I want to get to that next. But can we clarify before we get to the reason for mistrust and what we can do about it, and we hear from our audience? Can you talk to us a little bit about the COVID-19 virus, how it works, and how this mRNA vaccine works?
Sure. Thank you, Dr. Fowler, for inviting me to this panel. I really appreciate it. And the same to Bishop Abear for providing this platform for us. So I really appreciate the invite and the platform. So in general, vaccines work by training our immune system to prepare and recognize a disease process, such as a virus, before we are infected. So to help explain how the mRNA vaccine work, I'll put up a few slides. Can you guys see my slides? Good. So this is a cartoon of the coronavirus. Here's the virus. These red things on the outside represent the spike protein. And that's the protein that the virus use to infect the cells. So the way the mRNA vaccination work, and that's the work done by Pfizer and also Moderna are the two available here in the United States. This red squiggly line represents messenger RNA, and that's what mRNA is. Because RNA is very delicate, we have to put it into a lipid capsid in order to inject it into your arms and into your body. Um, that is the reason why Pfizer and also Moderna has very strict restrictions on the temperature at which these vaccinations can be stored and thawed and how long they can remain on the shelf before the protein is degraded. So after you get the vaccination, the vaccine goes into the cell and distributes this messenger mRNA into your cell. And then your cell becomes a factory for the vaccine. Your cell itself makes the spike protein. The cell itself does not make coronavirus. You cannot get infected with coronavirus with the vaccination. This is not the older way to do it or another way to do it using like the flu vaccine using eggs or things like that. This is not attenuated virus. This is not weakened virus. This is only the script on how to make a protein. That's all it is. So you cannot get infected with coronavirus via the vaccine. Once your cell receives the message, it starts to make the spike protein on the outside of the cell. So then your immune system begins to look for differences in cells. So it recognizes the spike protein. It also recognizes the fact that this is foreign material. This is not good. So then your cell begin to make, you start ramping up your immune system. So you make memory cells in order for you to produce antibodies the next time you see the infection. And you also produce antibodies on the spot. Now, those antibodies are very important because the antibodies are specific for the outside of the coronavirus or the spike proteins of the coronavirus. So when your body actually sees the coronavirus, the antibodies are present. It can block the coronavirus from infecting cells. So that's in jest in a cartoon how the vaccination works.
Thank you so much. So, if we don't get the virus, if we cannot be infected, why do we have side effects?
So the side effects is actually your immune system kind of ramping up. You can see things like even fever or feeling feverish. You can feel fatigue. The most common side effects from the vaccine is pain to the injection site, headache, and just kind of just feeling run down. You generally see that 24 to 48 hours after the injection, and it's more pronounced after the second injection. And this is specific for Pfizer and Moderna because there are two dosage delivered for the vaccination. So those are the things you see. Those are common. Those are not what I would call side effects. I would call that, an expected outcome of
Yes.
your vaccination is simply your immune system training and preparing for an actual infection. And hopefully you don't get an actual infection, but your body will be ready to fight the infection, so to curb the disease process.
Is it possible for someone to get infected after they've been vaccinated, like
Yes.
in a short period of time after they've been vaccinated?
Yes, actually, I got a small slide about that. Let's see, can I show that? So, in a short period after, let's see, can I show this? So, this is taken directly from the Pfizer vaccine. This is from New England Journal of Medicine. So, after you're injected with the vaccine, you can see. So, let me just describe this timeline first. So, this gray bar is folks who are actually vaccinated. This yellow bar are those who had the placebo. This is taken directly from the study. And you'll see that the folks who were, I'm sorry, the rate of those getting infected with coronavirus and those getting the vaccine and those who are in the placebo arm are identical for the first week. And that lets you know that the vaccine really doesn't work as well as you want it to work in the first week. You'll see at week 2, you're starting to see a difference between the placebo arm and the actually vaccinated arm. Coming into week 3, you're seeing a big difference between the vaccinated arm and the placebo arm, and this is where you're going to start to see your difference. In addition to that, Pfizer recommends the second dose of the vaccine around 20, I think it's 21, 22 days, and
Mhm.
Moderna is looking closer to 28 days, and that's when you'll see protection from your vaccination. So early on, you're not as protected as you want to be. I think another study showed about 50% protection after the first dose in the Pfizer study. However, when you look at 21 days and 28 days out, you're looking at 94 and 95% protection
Mhm.
with these vaccinations. Um,
Awesome.
you touched a little bit on warp speed, and I know there's some hesitancy about vaccination, and it's called warp speed, and it sounds like it's very fast, but it's important for everyone to know that the studies and the science behind these vaccinations, it didn't happen at the start of coronavirus. A lot of this started back in 2005, following the SARS endemic. And basically, for those who may not know, SARS look a lot like coronavirus that we're facing, COVID-19. In fact, they're both coronaviruses. And if you look at the longer name of coronavirus or COVID-19 is SARS-CoV-2, and that 2 is to distinguish it from SARS-CoV-1, which is SARS as we knew it in 2002. So
Mhm.
the science has been working since 2005 and looking at messenger RNA and how to use that as a way to vaccinate a little bit quicker. So, although in simple terms, it's almost a plug and play system where you simply plug in the RNA that you want in order to produce the protein that you want to provide the protection that you want. And because of the pandemic, you had a lot of funding going into this. Everyone is infected, or I'm sorry, affected by this pandemic. So you had more hands on deck. You had the resources. Everybody studying this. It had president. It had everything it needed for its success. So while warp speed is the name that we give it, it's a lot of science behind this, and it's shown to be very safe and also effective.
Thank you very much. I appreciate that. And I'm going to move to our closer, Dr. Keith Ferdinand. And I want to say I saved the best for last, but I definitely don't want to offend any of our other panelists. But Dr. Ferdinand, with all of your experience in medicine and all of your experience in taking care of our communities, hypertension was one of the number one health condition, chronic condition. And I know that you're a specialist in that. In your recent publication examining barriers to SARS-CoV-2 vaccination in African Americans, you stated that there is an urgent need for COVID-19 vaccination, with consideration to the poor uptake that we see yearly with flu vaccination and influenza vaccination. Why should we trust the science today? What's different today? What's different now than what has happened in the past that has caused African American communities not to trust some of the medicines and the science?
Well, first of all, I also would like to thank Bishop for this opportunity, and thank you, Dr. Fowler, and my colleagues who all have spoken so very well about the need to consider this vaccination. I don't tell people that you should take the vaccine. I suggest that we just offer our public the information and let individuals make their own choice. In terms of mistrust in the African American, it's not because our people are somehow ignorant or backwards. In fact, it's the opposite. Orthodox medicines, doctors, especially the white physicians, were the people who started the whole idea that people of African descent were inherently inferior. During the 1800s, many of the doctors would go into the slave quarters and get the young women and practice how to do their surgeries. If you look at the Tuskegee experiment, most of you have heard about that. When it was known that penicillin after World War II could cure syphilis, it was not even offered to these men. The experiment was just to watch them. There are other cases, even in modern medicine, where you had white hospitals and black hospitals, white wards and black wards. And even today, I'll see patients, and if I examine their feet or listen to their heart or their lungs, they'll say, "You're the first doctor who's touched me." So it's not because the mistrust is from ignorance, it's actually from experience. Nevertheless, I think this is different. If you look at the Moderna vaccine, and we had a wonderful description of the different types of vaccines and how they work. The two that are available, the Moderna vaccine, one of the principal investigators was actually a young African-American woman, Kismethia Corbett. She's 34 years of age. The other vaccine, the Pfizer BioNTech, although you see that big name Pfizer, Pfizer didn't actually make it. It was a company out of Germany. But it wasn't the typical Germans, Europeans. They were actually Turkish immigrant scientists who helped develop that vaccine. If you then look at the FDA and the CDC, we know that they have been unduly influenced by government from the previous president. But they had outside expert panels, and I've been on those panels before, where you go up to Bethesda for the FDA, or you go to Atlanta where the CDC is, and you have people who are not part of the government who look over that data, and that's how you get the emergency authorization. So there's a lot of moving parts in order to get these vaccines. Now, why is it important? I'm a cardiologist. I got into it because I found out that's what my people were dying from. Each day, 1,700 people die from heart disease and strokes. The second cause of death is cancer, 1,600. If you take 1,700 and add 1,600, that's 2,300 die from the two leading causes, heart disease and cancer. Those of you who are keeping up with the news now know that anywhere from 3,000 to 4,000 people are dying every day from COVID-19. That's the disease caused by the coronavirus. So it is now the #1 cause of death in the United States. So this is not Tuskegee. Remember, in Tuskegee, they withheld the penicillin. In this particular case, we have a therapy that is effective vaccine. There's the potential for getting infected and dying. Now, we're all going to die from something. But the other part of the coronavirus story is about 8 to 10% of people become disabled, freight across interstate. Because not only do you lose your taste and lose your smell, it may take weeks to months to come back. You then can have brain fog where you don't remember things, your muscles are weak. You can have scarring of the lungs where you're short of breath. And we even know young athletes who go back to the field of basketball and football, when they do scans of their heart, significant numbers of them can have what's called myocarditis. Myo means muscle, cardio is the heart. Itis is inflammation. They can have inflammation of their heart. So my take-home message is the following. The coronavirus and the disease it causes, COVID-19, is now killing 3,000 to 4,000 people per day. If you do the math, by mid-February, 500,000 Americans are going to be dead from this. But it's not just the death, there's also disability, and it's higher in the Black community. We are simple human beings with simple tools. We're not God. We don't give out life. But we have been allowed to develop this science using these vaccines, which have been so expertly developed in order to save our lives and to help us prevent disability. So I understand the mistrust. I understand the hesitancy. But if you look at the information, for our people, I think the vaccines are a step forward. And I have taken the vaccine myself. I recommend it to my family, and I recommend it to my patients.
Amazing. Thank you so much, Dr. Ferdinand, and certainly Dr. Fowler as well. I just want to let everyone in our streaming audience know that we do want to receive your questions. And so if you have any question for our panelists, we want you to go ahead and enter that into the chat, and we will read your question and have our panelists to address that. As you're putting your question in, I do want to also direct this question to Dr. Dennis, who very eloquently explained about the lag time in the uptake of the virus in our systems between the booster dose and the prime dose. The question is, should we still wear masks after an individual has been vaccinated? Is there still going to be a need for us to wear a mask?
The short answer is yes. And the reasons why is when you look at these studies, the endpoint was severe disease. They didn't look at whether or not you had infection. So in that case, you can very well have the vaccination. Like Dr. Ferdinand, I also am fully vaccinated, and I can still get infected with the coronavirus. However, hopefully I will not get sick, but that does not mitigate the potential for me to spread the virus to those near me and my family and friends. So I wear a mask for two reasons. I wear a mask to protect me from others, and also to protect others from me. So yes, I think at this point where the vast majority of Americans are not vaccinated, most are still susceptible to the virus just via the community spread. Yes, the short answer is yes. I will continue, and I recommend everyone continue to wear the mask for those two reasons.
Okay. And I'll just throw this out for whoever would like to respond to it. What will be the indicators that we will see to know that the vaccine program is taking hold within our state and even across our nation? How do we, what numerical data are we going to be able to look at and say, okay, this is starting to turn around?
Well, the first piece of information that we use on a daily basis, that the Department of Health uses on a daily basis, is the percent positive. So how many people are infected? We also add to that number because data, sometimes one number is not telling the full story. So you have to look at correlating data. And so we also look at how many people are vaccinated in comparison to the number of persons who live in the state. So the percent positivity is one of the health indicators that we should look at. Right now, the parish of Tangipahoa Hoe and surrounding parishes, except the parish I'm living in, St. Tammany, are going down. So from week to week, they compare the data, the percent positive rate. A few weeks ago, I think I did a message with you, Bishop, and the percentage was going up. But now with some restrictions, the percent week to week is going down. So we have to keep at it.
Thank you so much. Dr. Ferdinand, you spoke very pointedly towards the skepticism that's in the African American community specifically. Is there anything being done? I know you sit on the board with Governor Edwards' team. Is there anything being done specifically to encourage African Americans and to clear the skepticism so that they can feel more confident taking the vaccine?
Yeah, I think you're doing it tonight, Bishop. You are allowing the scientists, the doctors, the nurses, the epidemiologists to talk about these conditions. And then the individuals make their own choices. And you as a minister, hopefully we as informed clinicians, the community activists will become what's called trusted messengers. It's a term of art. It means somebody who has worked in the community, has lived in the community. I'm a child from the lower ninth ward. I just happen to have a degree. And if those persons can look at the data, can understand the science, and come to the understanding that it's good for our community, they are then trusted messengers. And that's different from somebody flying in from DC or flying in from New York and telling us what we should do. What you've heard tonight, very articulately spoken, are men and women who are doing this because they care, just like I know you care. And we believe that, of course, with some precautions, because there's nothing that's perfect. We're simple human beings. But overall, for most people, the vaccine is safe and it's effective. And it's about the only way we're going to get out of this pandemic, because that virus is looking for a host. It's looking for somewhere that it's going to live. It's like those bad movies where you had the monster that went through the town and was always looking for somebody to eat. Well, the virus is always looking for a host. And until we get 70% of people who have been vaccinated, the virus will continue to grow.
Okay. Dr. Ferguson, are there any additional things until the vaccine comes? And I'm going to ask a follow-up question in a moment about the rollout and who can receive the vaccine and when. Are there any things that we can do before the vaccination? There's a lot of skepticism around nutrition, around supplements, and things of that sort. Is there anything that the health community is recommending that the public can do to kind of help themselves in that regard?
I will actually push that question to Dr. Fowler and also Dr. Ferdinand, being that they are physicians or practitioners in terms of what's being recommended, from in terms of medicine and supplements. Because the answer you would get from me is what we've said before: is and continue to mask, continue to social distance, being aware, hand washing, those elements of what you can do before to protect yourself. As we move forward and as we get through this, pandemic, and waiting. I won't say waiting our turn, but that is it. Waiting and understanding when you are in line for the vaccine, when you have access. So us being able on the lookout to figure out when we're in the phase where you can get vaccinated, and where you can go and where we can target. And that information, or basically a hub for it, is on LDH's website. So on our Department of Health website for the state, they have all the places who have vaccines and the vaccine rollout.
Yeah, I'm happy to also let Dr. Ferdinand chime in. What I will say is that health is necessary to fight anything that your body takes on. Now, whether or not, if you are already healthy and you take additional vitamin D or the vitamin cocktail, which is something I have seen on social media, there is not enough evidence that I have seen to support that that boosts your immunity enough to prevent getting infected. Um, if you don't have health, if you have hypertension, diabetes, any of those things, those vitamin supplements will not cure your diabetes, which puts you in an immunocompromised state. Those vitamins won't fix your hypertension. They are supplements. They do help, but it's not the end all be all. Dr. Ferdinand, do you have anything else to add?
I agree, that was well stated. There are some data that people who have very low vitamin D don't do as well, but it may not be that giving vitamin D will correct that. Low vitamin D may also be a sign that that person hasn't been getting enough of outside activity, may not have been getting adequate nutrition. So it's not the low vitamin D per se, it is a correlate between poor health. In general, one of the questions becomes, well, how could we have this virus? I never heard of this virus before. They made it up in the lab somewhere. Well, I first studied history before I went into medicine. And we used to have big textbooks and whole courses on what happened to the Roman Empire. What happened to the Aztecs, the people in Mexico who built the pyramids? They're not the same people who are in Mexico now. What happened to Easter Island? It's an island in the Pacific where they have big stone sculptures, but nobody lives on the island. I think what we are now learning is we don't run this planet. We are part of this planet. The viruses, the bacteria, the parasites, they're here too. And they can wipe out a whole civilization. We have the opportunity because we are given the ability, the free will to change our environment to fight off the virus. But I agree with Dr. Fowler. You can't just take a pill to fight off the virus. You need healthy lifestyle, sunshine, exercise, clean water, good nutrition, and a vaccine. I had to throw the vaccine in there, Doc.
Absolutely. Absolutely. Thank you for that history lesson as well. Always appreciate you, Dr. Ferdinand. There was also someone mentioned about herd immunity. I believe it was Dr. Ferdinand. Herd immunity can take place two ways. One is enough people get the disease and get over it. Another is enough people get the vaccination. Is there a difference between someone who has recovered from COVID-19 and receiving the vaccination? Is there a difference in how our bodies mount an immune response as a result?
I'll let Dr. Dennis take that one because he spoke so eloquently about the vaccine in terms of just getting the virus and working your way through herd immunity versus the vaccine. Dr. Dennis?
Sure. So herd immunity is defined as 70 to 80% protection, and the whole idea behind herd immunity is different from the vaccination. Herd immunity is basically getting the infection, and then through your body's own way of fighting coronavirus, you develop the antibodies, and you're able to protect yourself not only in this instance but also in the future. That's the idea behind herd immunity. And when you say 70%, I mean 70% of the population. So 70% of said population would have that exact same response. So if you're, let's just give an example of 10 people in a room, and the 11th person has a virus. If 70% of the people are protected, the three people who are not protected in general, in theory, are protected by the herd or by the seven who have antibodies in protection. So that's the gist of herd immunity. That doesn't go hand in hand with the vaccination. There's going to be a slightly different antibody response. With the vaccination, you're making a specific protein against, a specific antibody to the spike protein. With herd immunity, that means you've been infected already. So you're making an immune response against different parts of the virus. So it's not quite the same, if that makes sense.
Absolutely. Now, follow-up question to that. We've been reading in the news over the last several weeks now about the variant strains that are coming out. I believe today I read about a Brazilian strain now. There's a South African strain. There's a UK strain. And all of these are mutated virus. Will the vaccines protect us from all of these mutants that are coming as a result of the virus changing?
That's the idea. So as far as I read the same about the Brazilian strain, and the Pfizer came out with a statement, not a study, but a statement saying that there is protection from the Pfizer, and I would assume the same for Moderna. Viruses mutate. That is the natural progression of viruses. On average, coronavirus is mutating. I think I read 7 nucleotides per person, and that's not a big variation. And with the vaccine and with your natural immunity, the antibody is to the outside of the coronavirus, the spike protein. So all of these changes could be in the inside of the virus, and that won't matter as far as the vaccination is concerned. Now, again, we're within a year and a half of actually sequencing this virus. That's not to say maybe 5, 10, 15 years down the road with multiple mutations, will the vaccine be effective? But remember, the two vaccines that we're talking about, the mRNA vaccines, they're plug and play systems where if you have a variant where you don't, where the previous vaccine doesn't work, it is not very difficult to change the sequence of the mRNA to produce the spike protein that most resemble the new variant. So they haven't come to that point where that's necessary yet. Maybe that may not come about, but the technology is in place for a variant or a mutation that's not covered right now.
Bishop, the problem with us waiting till we reach herd immunity through so-called natural is that you only so far who've been infected, and almost 400 to get to herd with so-called natural path. You're going to have two by making all of those people immune so that they don't get infected in the future. In terms of those viruses, like Dr. Dennis says, they're always changing. They're like Muhammad Ali in his prime. They on their toes, they're dancing, they're moving. You got to knock it out while you can. If we wait around and we wait on so-called herd immunity, a bunch of people are going to die. And by the time the vaccine comes into play, it'll be too late. So that's why, again, it's an individual decision. I'm certainly not here trying to convince anybody. I've been vaccinated and I have my family vaccinated. But in this particular case, if we wait for herd immunity, it's going to be too late. And we know the congressperson from North Louisiana, 41-year-old Caucasian guy, healthy, big, strong looking guy, he died. So it gets older people, it gets people with diabetes, just like Dr. Fowler said, and hypertension and heart disease, but it can get a healthy young person too.
Very
Bishop,
good
one thing I
information.
want to add in, I agree with everything that's been said. So of course it's in total agreement, but it's to also for us as a community to when there's a potential change in message for us to still trust the science because things are evolving and we're learning more. So if we do have to have another vaccine, come available because we have the plug and play system because of the variant, that's okay. We didn't get it wrong the first time, is that the science is evolving as the virus has evolved, and there might be, additional processes or additional vaccines later, or there might be adjustments made. But there's not, I don't want us, we have to accept that that's not a mistrust there, but we are having to go where the science takes us. So the more we know, the better we can do it and the better prepared we can be.
Thank you so much for that. All right, one of our staffers is manning the chat line, and we want to select a question now to present to our panel. If we could ask that question now.
If you have had the virus, how long should you wait to receive the vaccine, or should you, in fact, receive the vaccine?
Well, you shouldn't get a vaccine if you're sick. But if you've just been infected and you turn positive and you're stable, it's still recommended by the CDC that you get the vaccine. You perhaps would like to wait 14 to 30 days. If you're ill, you're coughing, you're sneezing, you're wheezing, you shouldn't get the immunization. The reason they suggest that you still consider the vaccine after you've been over the acute illness and you're stable, you don't have any symptoms, is because we don't know if that natural immunity is going to last. We know it's about 3 months, maybe 6 months. We think the immune response from the vaccine is superior to that with even the so-called natural immunity. So it's suggested that you consider getting the vaccine even if you previously had coronavirus.
With that being said, Dr. Ferdinand, do you foresee or is there any literature that is out that's saying that we're going to have to get this on an annual basis or every 10 years? Is there any direction at this point to let us know what we're going to have to do down the line?
I think Dr. Dennis pointed out that there's a lot we don't know. It's a new virus, and it's suspected that the vaccine will last at least a year. I would not be shocked. And Dr. Fergus made this point that there are changes in science, things come up. I would not be shocked if they learn that the vaccine immunity wanes off after a year and you have to get it each year. But my best guess, again, we don't know, but my best guess is that if you get these new vaccines, you'll be well protected over a year.
Okay, we'll go back to the stream questions.
Do you recommend the vaccine for people with allergies, COPD, and any underlying health conditions? And if so, what process should these people take?
Dr. Dennis?
Yes. So yes, I do recommend the vaccination for those comorbidities that you spoke of, and particularly those comorbidities that you spoke of, particular hypertension, COPD, obesity, and things like that. Those are the guys who are more vulnerable to severe disease rather than just the infection where the patient can stay home. As far as allergies like pollen in tree and grass, that is different from the worrisome reaction or the anaphylactic reaction that we've heard from the vaccination. There's been, I believe, 11 cases of anaphylaxis after receiving a vaccination. And all of those patients did fine. All of those patients had a history of severe anaphylaxis to several things. They all had EpiPens with them. So that the patient was already informed, and that lets everybody else know that these patients already were very sensitive to certain things in the environment. So that's quite different from just your normal sinus and allergy patient or your normal tree pollen. So yes, in short, I do recommend the vaccination for the comorbidities that you mentioned.
And I
Okay,
think
that
it's
sounds good.
also important to understand that in the clinical trials, there were persons who were a part of the trial with diabetes, with hypertension, with comorbidities, and they did fine. There was a small percentage of persons with the worst complication, which was anaphylaxis. But that is not drilled down to whether or not that's related to their chronic disease. It's because of some part of the medication itself. So it is more risky not to be vaccinated and have those underlying conditions than it is to be vaccinated with those.
Dr. Fowler, I think the current recommendations are just as you and Dr. Dennis have indicated, but the numbers, it's no more than 1 out of a million. So it 10 maybe out of a million is at the most. It's not something that you're going to see on a regular basis where people are getting the vaccine and falling out. Those people who have a history of really severe reactions, like Dr. Dennis says, they have the wheeze and the hives and they're passing out from previous allergies, they should wait at least 30 minutes. If you have an EpiPen, bring the EpiPen. But if you just got sinus congestion, the regular asthma, low hypertension, diabetes, etc., that's not the type of person who's.
Okay. I have another question. There's a lot of controversy, not necessarily here in our state, but certainly in other states I've seen with should the states recommend that schools open or stay closed? As it relates to youth and coronavirus, what is the data suggesting as it relates to their transmission? Are they protected more than adults are? Can we kind of speak to that to some of our parents who are concerned tonight?
Well, I'll take a stab at it. I'm in a college setting.
Hmm.
And so we made sure that we have adequate PPEs for our faculty, that we build plexiglass. We have hand sanitation stations set up. So we have all the physical infrastructure in place to safely hold class in small sizes using a hybrid web-based platform, and if they're going to be face-to-face, in small, separated safely. It's just the research is still undergo as to what this social isolation is doing to our students. College is all about socialization, and so there's a lot of isolation that's occurring that's having some mental impact. We're seeing anxieties, we're seeing depression, we're seeing suicide rates up in that 18 to 29-year-old group that we've never seen before. And so this coronavirus is not only affecting us physiologically, but is certainly having a psychological impact on our students, particularly those, in the college age.
Yeah. The latest now, the disclaimer is I don't take care of pediatric patients. That's not my area of expertise. I do work with pediatric experts, and some of the information that has been published, some of the information that they're seeing in practice, particularly at Children's Hospital, they're a very close partner of our school, is that there is a smaller percentage of children who are having a severe infection. We call it the multi-system inflammatory syndrome in children. That infection causes inflammation of the tissue in the lungs and the heart and the muscles, different organs at an alarming speed, and is very unpredictable. Now, with the transmission rate, I don't know the research and I don't know the information that's out there. I would suspect that the transmission is the same in children as it is in adults. The uptake of infection and the severity of illness is variable, is what we see. Should our children go to school? I think that's a personal choice. As long as the school is providing mitigation measures, as long as the school is taking it seriously, as long as the parents would have comfort in sending their children, well, I think that's a personal choice. We know that the vaccine is indicated for 16 years and older. So hopefully, if we have enough of individuals who are 16 years and older that are vaccinated, that we develop some passive immunity, that our children can also be protected and we have more normalization.
Thank you so much for that. I also peeked into the chat, and there's a lot of people asking questions about should the vaccine be recommended when people have other underlying conditions, such as specifically heart disease, recent heart surgery, and I think someone already answered the sinus issues as well. Dr. Ferdinand, is there anything that would prohibit a patient from getting the vaccine if they had any type of severe heart disease?
No, I recommend the vaccine for all of my patients who have heart disease. Again, if you're sick, you just were operated on last week and you're recuperating, you have an open wound, then that's not the time for you to have an immune response thrown in the mix. But if you're stable after heart surgery, after an angioplasty, heart failure, chronic kidney disease, those are the persons who benefit. In fact, along with the healthcare workers and the people who are 70 years of age, the governor pushed up people who are on dialysis with chronic kidney disease to get the vaccine first. The CDC said you could drop it down to 65 years of age or to people who have multiple medical conditions. We didn't do that in Louisiana because we didn't have enough vaccine to go around. So the governor in his wisdom said, if I say to all the people who are 65, and we know of all the hypertension, diabetes, heart disease in Louisiana, if I say everybody with multiple conditions, everybody who's 65 is eligible, then we wouldn't be able to deliver on the vaccine. The CDC made that recommendation based on the science that Dr. Fowler has already articulated, that those high risk patients actually do better. But we just didn't have enough doggone vaccine in Louisiana for the governor to make that recommendation.
Yeah, can we talk about distribution? Because I know even in my family, I've had relatives to have their appointments canceled for their vaccinations. Where are we as it relates to our distribution of the vaccine and stocking the vaccine here in the
I'm
state?
on the vaccine commission along with many hats, and there was a meeting last week, and that is why the governor decided not to expand it to 65 years of age and people with multiple conditions, because we did not have enough vaccines. They wanted to hold the vaccines that they had to make sure the people who got the first shot would have the second shot. Now there's a new sheriff in town. The new president has said that he is going to give people enough vaccine by the end of the summer that everybody can get it. And presently he's going to increase by 16% the amount that's delivered to the states and give the states at least a week to 10 days heads up when the vaccine is coming. Prior to that, it would only be about 3 days in which the state would say, you're going to get another shipment. So it's hard to make recommendations on giving vaccines when you didn't have vaccines. Without being political, this is a fact. It may sound political to some, but this is a fact. The previous president didn't really care. He wasn't paying attention to the distribution at all. He felt that whatever happened was going to happen and let somebody else take care of it. The federal government really needs to coordinate that distribution to help the states in order to get the vaccination to the people. To just get it made and have it shipped into the warehouse, that's not the same as immunization, which is getting the vaccine to the people. So I think we're going to see better. It's going to take about a week. I don't know when the governor is going to drop it down to 65 and people with chronic conditions. But soon as he can be assured and the Louisiana Department of Health can be assured that we're going to have enough vaccine, I think you're going to see expanded to 65 and people with multiple conditions.
I think the other piece to that is to understand the fragility of the vaccine. And Dr. Dennis said made a very, very important statement regarding the fragility of that lipid capsule, that fat capsule that carries messenger RNA in the medication. Dr. Ferdinand mentioned that coordination is important. At the LSU School of Nursing, we are a point of distribution. Right now, we're a closed pod for the vaccine. With trying to prepare it. And this is very important for our members to hear. When it's time for you to be vaccinated, you will need to make an appointment. This is something that if you walk up to and you don't prepare for, you might not get vaccinated. It requires that we keep the vaccine, the two that have been approved, in very, very low temperatures. There's a period of time it has to be thawed. There's a period of time that we can only prepare so many for the people who have made appointments. So it is not simply walking up to the pharmacy when pharmacies are able to distribute them to the community, or walking up to your doctor's office and saying, hey, can I get vaccinated today? Coordination, yes, we need to have the vaccination. We need to have it delivered to the points of distribution. That's very important. But then there's a lot of coordination that goes to getting that shot in your arm. So just be prepared. When it's time, please make an appointment. The many of the public health messages will push out where you can go. That is not decided completely just yet. Many pharmacies are due to get them, doctors' offices, many other places. But just be prepared to make an appointment, because that vaccine, that shot will be prepared for you.
Thank you so much for that. Can we go back to the stream for one more question? I think we have about 2 more minutes left.
Yes, the last question says, has extensive research been conducted on the long-term effects of the vaccine, and is Pfizer more preferred over Moderna?
I'll split this one with Dr. Dennis. I'm going to take the easy one. Pfizer and Moderna use the same platform. They're about what and what. The United Kingdom is so low on vaccines, they're starting to mix and match. The CDC says we shouldn't do that. So if you get the first shot from Pfizer, 21 days, get the second shot from Pfizer. If you get the first shot from Moderna, 28 days, get the second shot from Moderna. But they're very, very similar in terms of their efficacy, 94, 95%. They're about the same. Dr. Dennis, there was another part to that question, I think.
Yes, the long-term effects. That is a more difficult question. The simple answer is we don't know. The vaccinations began the latter part of 2020. So we're maybe 4-6 months into this vaccination program, and it's going to be very difficult with accuracy to say what are the long-term consequences. The good news is that once you are vaccinated with the messenger mRNA, what happens is your body actually degrades that message. So you're not worried about the message itself producing proteins you don't want. So that's something positive, and that may speak to some long-term protection or some long-term preventing complications down the road. But the true answer is we don't know, and that's to be determined.
All right. I'll give any closing comments to Dr. Fowler.
Well, one closing comment I have is thank you to our panel. I think that this was made rich by your experience, by your knowledge, by your compassion for our communities. And I am just so grateful to you all, and greatly appreciative that you accepted the invitation. I hope and I pray, it's my prayer, I was just speaking to Lady H earlier today, that even if you don't change your mind and you choose that you don't want to be vaccinated, that is your choice. But I hope that you have increased your level of knowledge, and we have helped to dissipate any myths, any fears, anything that comes to steal away information and knowledge, right? So that's my prayer, and I hope that that was accomplished tonight.
Yes, I echo that as well. Thank you to all of our distinguished guests tonight. I think everybody that's streaming tonight ought to put a clap hand emojis in the comments for all of our panelists on tonight. They did a phenomenal job. Y'all cannot deny that these were class A panelists and physicians and experts in their particular areas of expertise. And we truly, truly appreciate each and every one of you tonight. I hope you've enjoyed this conversation. I know it was a little lengthy for what we usually do on a Wednesday night, but I think that this is something that all of us should not only just receive, but if you don't mind, like, share, and tag so that those who are watching, even after this broadcast is over, can get this information so they can perhaps make life-saving changes in their decision-making process to be vaccinated. Thank you again to all of our panelists. As we close out tonight, again, to all of our church members, we appreciate your support, your love, and your generosity towards our church. And we're going to continue to give you opportunities and ways that you can sow into our ministry so that we can continue to do the things that God has called us to do in this community and even abroad. The information, of course, to sow into our church tonight. If you want a text to give, you certainly can do that. That information will be in the chat room. If you want to give on Cash App, we thank you and bless you so much for all of your contributions that you're giving towards our church. As we continue to say in our church, we don't fight for victory. We fight from our place of victory because we know that the victory is already ours. Listen, have a blessed night. And please remember that knowledge is power, and we are living